can talk very quickly on what is the role of a radiologist while doing response scans. So basically there are response evaluation criteria which have been developed to standardize reporting, and we have endpoints based on cross-sectional imaging, that is CT scan for lung cancer. And of course we identify the target and non-target lesions at baseline and then we follow them up. The commonly used response criteria are historically the WHO criteria, then RECIST, and the new revised version which is now commonly used is RECIST 1.1. We can see a timeline here of how with the development of immunotherapy and progress in the functional imaging, we have the need of the hour was to develop an immune-based RECIST criteria. So there are two, that is immune-related response criteria, that's IRRC, and the modified immune-based therapeutic RECIST, that is iRECIST. So what is RECIST? It is basically an objective method of assessing a change in the tumor burden, especially after cytotoxic chemotherapy. And as mentioned, we identify target and non-target lesions. The selection criteria for the target lesions are, longest diameter of non-nodal lesions, whereas for non-target it is less than 10, and nodal will be more than 15 for short axis and less than 15 short axis for non-target lesions. What is important to remember here is that we select up to 2 lesions per organ or up to 5 lesions in total for target lesions. And SOD, that is the sum of diameters of all target lesions, is calculated and then reported as baseline, which is then followed up in the subsequent follow-up scans. The response is categorized into 4, that is complete response, a partial response, progressive disease, and stable disease. I will not speak in much detail of what is there, is presented on the slide. It's important here to know that progressive disease is at least a 20% increase in the sum of diameters or development of new lesions and an absolute increase in 5 millimeters. Partial response, to be borne in mind, is in at least 30% decrease in the sum of diameter of the target lesions. And stable disease, as the name suggests, and complete response, of course. For non-target lesions, it's similar. We would call a progressive disease when there is unequivocal progression of existing non-target lesions or there is development of new lesions. And a complete response will be disappearance of all lesions. And when it does not fit into either, we have no response, no progression. It is important to remember that non-target disease progression isolation is rare. However, we do see cases at our center sometimes. I have a few examples here. This was a 42-year-old male. We have 2 scans which are 10 months apart after starting of chemotherapy, and we can see that the lesion is decreased significantly in size but not completely gone, and this would be categorized as partial response. And another patient, we've had serial CT scans of this patient. He's been following up for many years, and we can see that the disease has been stable. And a patient with metastatic NSCLC, she had pleural deposits, EGFR ALK negative, and was started on 2-drug combination. And the 2 consecutive scans here had shown progressive disease because we can see that the size of the lesion has increased. So the limitations with RECIST are, of course, as I said, we take the longest diameter, so the area or volume is not considered, and neither is the solid component of the lesion. The enhancement of the solid component. Sometimes response in tumors is development of cystic or necrotic changes or cavitation, which if the overall size is the same, again, is not considered here. Or if there is a change in relation between the tumor and adjacent important structures, especially vessels. So the question here is, can it be confidently used for assessing lesions that are treated by immunotherapy? And the answer to that was, of course, not always, and thus the introduction and the inception of iRECIST. However, no clear consensus has existed for response patterns when we use different immune active agents. And the usual the unique responses that we have been seeing with development of immunotherapy is pseudoprogression or hyperprogression. So in this, we see an initial increase in size of the tumor or development of new lesions, following which there is a delayed tumor response. I will just introduce you with some of the new terminologies we use, and we'll move on to a more graphic example after that. So there is IUPD and ICPD, which is immune unconfirmed and immune confirmed progressive disease. The first scan that is taken after starting of immunotherapy is at time point. If there is an increase in size of the lesion at that point, or if there is development of new lesions, it is termed as immune unconfirmed, because we need to take another scan at least at an interval of 4 to 8 weeks to see whether it is a confirmed progression or there is a change into either partial or complete response, or there is a stable disease. So representation, as I said, baseline scan, starting of treatment. Now time point 1 can have either increase in size or new lesions, and this happens because of immune cell infiltration of the tumor by edema. And time point 2 will then give us the true picture. We have two cases here. We can see that between the baseline and the second scan, these are two separate cases. Between the baseline and the first scan taken after beginning with immunotherapy, we can see that there is flare-up of apparent flare in the disease, but a follow-up scan after that is showing successively decrease in size. We need to remember here that with NSCLC, there is a very low proportion of patients who would actually show pseudo-progression, but the concept needs to be kept in mind, because when we do a follow-up scan and there is an increase, the treatment should not be changed immediately at that point, and a decision should be taken after the second scan. The follow-up scan should be done at least 4 to 8 weeks apart. However, even several months later, we can see pseudo-progression in some cases. And there is no valid biochemical or radiological marker yet which can differentiate true versus pseudo-progression, hence the importance of follow-up scans. A very short talk, I would like to give few examples with immune-related adverse events. These are basically attributed to autoimmunity and infiltration of autoreactive T cells. And the ones that are identified in radiology are colitis, hypophysitis, pancreatitis, hepatitis, arthritis we would see, and thyroiditis and pneumonitis. So in either of these cases, either there is the treatment can either you can give steroids, or you can either delay or discontinue the immunotherapy temporarily. The patterns that are commonly seen are most commonly cryptogenic organizing pneumonia, and of course NSIP, HSP, AIP and ARDS are other common pneumonitis features that are seen. In situations like this, one must bear in mind that the bacterial pneumonias and radiation-induced toxicities need to be differentiated from immune-related adverse events. The other radiologically identified adverse events are, as I said, colitis, we can see in the first case. There is hepatitis, development of hypophysitis. This is and thyroiditis. This was one of the cases we had in our department itself, where there was development of atypical press following levatinib treatment. The take-home points here would be that radiologists must be aware of the mechanism of action of chemotherapy and immunotherapy and the implications that it can have and the changes that it can have on imaging. The applications of RECIST 1.1 and iRECIST for not only standardizing the reporting, standardizing the treatment plans for the patient, but also for clinical data and for future trials. And the recognition, early recognition and spectrum of imaging findings in immune-related adverse events.
Thank you, Jinita. नहीं, सवाल ही पूछने के लिए बोल रहे हैं.
So, with targeted therapy response, of course, we would see hyperprogression in those cases too. But again, like doing a follow-up scan would be imperative at that time. Yeah, in such cases, actually, especially with iRECIST, the use of functional imaging, that is FDG PET, has.
I can answer that actually. So definitely the RECIST has some limitations. It might have change in the attenuation. It might get from solid to cavitating. It might go into the cavitation, or there might be decrease in the enhancement. So there are many other parameters apart from the size itself. We have to take into account when we are calling it as a response. So for trial purpose, we are limited what we have decided. We follow RECIST 1 or RECIST 1.1 or whether if it is immunotherapy, we have to follow the IR assist. Apart from that, there are many other things that we are going to follow to label them as a response. So if there is a development of the cavitation, it will indicate that probably it is a response. If it is a development of lower down the attenuation from solid, it becomes semi-solid, or it becomes ground glass, again it will indicate that there is response. So, and it has to be corroborated with decrease in the size and other things. So these are the things we take into account for the any therapy. May not be the targeted therapy or the cytotoxic therapy or the immunotherapy. I think Vijay, if we are not wrong, that patient's clinical status has to be into the mind. That is something which not any of the RECIST criteria is talking about. Especially if we talk about the immunotherapy, if the patient are good and we see that there is a remarkable progression in the disease, at that time we have to see that whether there is an increase in the ground glass densities around the solid areas. That will give a clue whether probably there is a change of pneumonitis that is happening around the nodule. If it is a clear-cut progression, the solid component will increase more drastically as compared to the. So it will give probably we are dealing with a pseudo progression, and then how we will take about it. So there are certain limitations on imaging, but these are the clue when we don't have a mass formation and we have fuzzy appearance around the thyroid, around the fatty stranding around the pancreas, or having a low attenuation of the liver or some fatty densities around the liver. So these area when we can pick up the toxicity apart from the other site of where the tumor has been there. I think SAIC is there, so I just want to know definitely the anatomical imaging. So whether there is anything, any molecule, because most of them it is an inflammatory driven uptake. So whether we have to do a FDG in that scenario, or we have to do some other molecular imaging that can predict or that can differentiate between an immunoprogression, pseudo progression versus a true progression.
Other molecules, so like you have irises, so we also have iPersist or persist criteria. So those are also similar type of criteria on follow-up scans. There are a few other molecules, but those are all mostly in animal models or experimental studies, like that sees tumor neoangiogenic decrease in tumor neoangenesis in certain kind of targeted therapy. So those kind of things affect more as compared to the volume of the disease. But in humans, applications have been limited so far. So far we have, and regarding immune-related side effects, adverse effects like colitis and all, so those kind of things are very predominantly seen in FDG PET, but the pattern of those uptakes and all, you can pretty sure, okay, if it is colitis or thyroiditis and all, those kind of things.
To Vijay, anyone can answer. So what is the percentage of pseudo progression that we will come across, or it is higher in certain set of tumors, or it is higher in certain set of histology, or can anything, there is any data on that?
So when immunotherapy initially came, there was a very huge fuss about pseudo progression, but that was rightly pointed out in one of the slides. It's actually in lung cancers, it's very few. So lung cancers, this rate will be around 1 to 2%. In head and neck cancer, it is all the lesser than that, around 1%. When do we suspect pseudo progression is when there would be, that the patient actually will be saying that he is symptomatically benefiting. You would see that the patient's performance status has increased, weight has increased, patient can do more activities, the symptoms have decreased, but the scans are showing on the opposite side, that the lesion has increased. Or many times what would happen is there's good reduction in the size of the main tumors and some new lesion has appeared. So these are the two scenarios when we start suspecting that this would be pseudo progression, and then we continue the therapy and get a scan done within 1 month just to see whether it is there or it is not there. Because it's apart from when we see progression and resist, we always and this message is especially for residents that we focus too much on radiology only. If the patient has a clinical progression, which means that if the patient has a skin nodule, if the patient has, in head and neck cancers you can see a new node, whether reported in radiology or not, it is a progression. Even RECIST, the full paper actually allows you to measure the things with calipers, obviously, because it is not that objective. Most of the pharma trials don't allow that. But if the patient has a clinical progression, which means it is clinical progression, which means that it is progression.
Yes, I have one question, sir. Actually, sometimes, no, what I notice, sometimes patient have infection, and it in the head and neck area, and it becomes difficult. And what one of the commonly infection is actinomyces, and generally antibiotics are given. They are very sensitive, and you never know whether it is progression or it is infection. So it is difficult. And sir, just I wanted to make one comment regarding PET. Recently, I had a patient who was neuroendocrine tumor, had neuroendocrine. After treatment, the uptake had gone down, but it had increased in the size. So it was very baffling for us ki why the uptake has gone down and it is increased in size. So no, it was a neuroendocrine tumor of liver, which was spread to spine and lung. And after giving octreotide therapy for 3 months, the uptake has gone significantly down. Dotapet. The uptake has gone down, but size has increased a lot. Yeah, so they actually it got transformed and actually it turned into something else. So we did a repeat biopsy to confirm whether it is really that. It turned to be grade 3. Huh. It will go to FDG. Yes, yes. So similarly, sometimes in TMH, PSMA uptake goes down, but there is increase in number. So it has transferred to neuroendocrine tumor also sometimes. It is a coincidental tumor or it has transformed into.
Timing in respect to what? This is the first time the scan has been done after the treatment. So in that we cannot label it. We will, if it looks to be progressed, and if it is an immunotherapy, and if we are suspecting pseudo progression, we will label it as an unconfirmed progression. Only at the time of second scan we can label that this point of time whether it was a true progression or not. That is only can be known after the second scan.
Progression, if you see the JAMA Oncology paper, which actually has given a good objective criteria for saying what is an hyperprogression. So which says that for hyperprogression, you need to have at least one imaging before that. So for example, the concept comes in if you are going to use your immunotherapy in second line setting. So let's say that I gave in first line setting, the patient progressed within 4 months. Okay, in the second line setting, the patient was a so rapid progression that I have the velocity of growth of the tumor, and that actually exponentially is doubled or more than that. That was actually the definition which was given. That the patient is actually hyperprogression. Again, hyperprogression is a very, again when immunotherapy papers came up, it was brought, you can have pseudo hyper, it's very rarely seen. Again, clinical picture, the patient deteriorates very rapidly. In fact, we had a patient last week, and Dr. Suman had seen the scans. We had given patient durvalumab, 1 dose. Within 3 days, the patient came back with severe symptoms. We were suspecting that he developed pneumonitis, maybe radiation-induced, maybe this induced. He may have developed pulmonary thromboembolism because it's breathing. And when we did the scan, the disease frankly increased. So the thing is that in pseudo progression, most of the times the symptoms are such that the patient is benefiting. Hyperprogression, the symptoms are that the patient itself will tell you that it is not benefiting. That helps you into it. And what Dr. Amit is saying is correct. For trial purposes, you need to have a scan done after 4 weeks to confirm. In fact, in RESIST, per se, if you read the full paper, even to say that there is a CR, you need to have a scan done after 4 weeks to confirm that. Even to see a PR, that has to sustain for that at least 4 weeks. But practically, in day-to-day clinical settings, we don't take that, but in trial purposes, we do that.
histological property of the tumor itself. There is probably release of lot of inflammatory markers. So are there any work being done that when you have pseudo progression, is there any role of looking at inflammatory markers to see whether there is any progression?
So there, this concept initially came, people looked at whether the high PDL1 hai, TI, TIL के लिए सब question, but none of these biomarkers have been able to, not only for progression, even for telling whether the patient would respond or not. In fact, in between we have STK, STMBs and E's. Many of the genes were also said that these will, if they are there, the chances that the patient would have developed resistance. But none of these have been validated in any big studies. So at present, it remains clinical and clinical. For us, the problem becomes all the more acute, Naveen. For example, these immunotherapies are costly. Someone is paying 3 lakhs per dose. And to tell the patient, okay, in the scan it shows progression, but you need to take it 6 lakhs. It becomes a bit difficult. So one part was emotional, one part is a big financial burden, because then you would say, okay, I would like to preserve those 6 lakhs for another form of therapy, which the patient might. Yeah, so it becomes an issue with pseudo progression and hyperprogression.
We did see, but not to the extent that we see in chemotherapy.
So
It's possibly not just the biology of the disease, but also
it is the interplay between the immune system. To be well, we have seen this phenomena with metronomic chemotherapy. We have seen this phenomena. So I think those therapies which have an impact on microenvironment, it seems likely that in those therapies that is that, and it may be true also, because up till now whatever science we have developed on the basis of drugs which had actively impacting on the tumor. So we know that, okay, this decrease matlab ये होता है, this interplay of using those therapies which have a microenvironment has been starting in this recent era. So if you see in bevacizumab, we used to have the concept of pseudo responders, where you would see a rapid shrinkage, but that shrinkage was nothing only but that is a drastic reduction in edema, and after some time the patient used to progress.
Actually, in HIV, it is already known, sir. When you less CD4 count of 30, 50, you start anti-HIV drugs, patient goes into iris. There's a immune reconstitution inflammatory syndrome, type 1, type 2. So those patients, due to increase in immune system, sometimes they have cerebral edema also and pneumonitis also. So it is known whenever you give something which is inflammatory, they might cause this kind of things.